Thank you very much, Tom. It's a pleasure being back in Los Angeles. And I think being in LA, you have to start something to do with the movie industry. Actually, but unfortunately, it's not very good news. Most of you probably know Angelina Jolie. A couple of years ago, there was an op-ed in the New York Times where she announced that she had a double mastectomy following BRCA testing. BRCA, which is two genes, BRCA1 and BRCA2, two genes that are associated with elevated risk for breast and ovarian risk. And following her announcement, as is typical with cases where a celebrity announces one thing, there was a spike in the number of women who seeked out the genetic testing for BRCA1 and BRCA2. In the UK, it was 2.5 times. In the US, the estimates were twice as many women. And there was actually a spike, surprisingly, in the number of women that wanted to have a double mastectomy. Whether they actually needed that or not was not the case. So many women, even if they did need that, wanted to have that. So this issue has raised a lot of concern now about genetic testing. Now, Angelina Jolie, unfortunately, is not the only one to go through the process. A couple of years ago, the New York Times had a similar op-ed about the similar issue, only this time with Deborah Lindener, I hope I pronounced her name correctly, who's a medical doctor who had precisely the same issue. She was diagnosed, or she went to a genetic testing, and it was found that she has the genes. And she wrote in the op-ed, "I have the amazing gift of knowing my risk. How can I not do anything about it?" And this is really a fundamental issue because we give information. I don't know if anybody here is in the business of giving information to patients or to consumer in various forms. And we think that the moment that we give the information, individuals actually can utilize it, and actually more importantly, do they understand the information that we give it. Whether it is about medication, whether it is about tests. I don't know how many of you have gone to the doctor and had any sort of test, but when you get back the information, the physicians, or whoever it is, might assume that you understand it. And that might not always be the case. And this is what I would like to present, some work where we show some of the difficulties that there are in the area. So women, I will concentrate on women here, but we have data also on males, so there's no real gender differences. So women know their lifetime risk, but do they understand it, which are completely different issues. Angelina Jolie and other women use that information, so the BRCA test data or information actually is used for them to make the decision. And the question is, how do they understand it and use it? As I said, lifetime risk, when you get the genetic test back results, it gives you some data about your lifetime probability of developing breast cancers and ovarian cancer. And women, in this case, but also men, use this to make decision about treatment. Should I do double mastectomy or some other kind of treatment? But also for family planning. So with regard to should I have children now, should I wait, etc. So it has a lot of impact, or it could have a lot of impact for women decision making. Needless to say, genetic testing, this is sort of a background, some of the issues. Needless to say, genetic testing has become a more and more prominent area in the medical setting after the genomic work. We have far more tests now than we ever had before about genetic testing, and it has a lot of merit. It gives you knowledge. So if you do genetic testing now, there are prolific area of you can do tests. It gives you knowledge, first of all, whether you are a carrier of a certain gene or not. It allows you to have early surveillance, whatever it is in the domain. In some area, you can do a lot. In some areas, you cannot. And you can do interventions. And you can notify family members. So if you're a mother or a sister or a father, whatever it is, you can go to your rest of the family member and say, look, I'm a carrier, you might consider testing as well. So there are a lot of issues with regard to that. And in fact, when we ask, or when researchers have asked both patients and genetic counselors, in different countries actually who provides the information is slightly different. In some countries it's mainly physicians, some countries have genetic counselors that are doing, in other countries it could be nurses, so there's a plethora of options on the healthcare providers that can actually dispense this information. But generally speaking, all rated as highly important and pivotal in the consultation about the nature of the disease and what to do next. So all rate really highly the nature of this information. So when people have started to look, and I don't know how many of you, aside from Beth that I know that is working in this area, I don't know how many of you have worked in the area of risk communication or patient communication. We know there are many challenges in the domain of how to communicate risk information. But this is not only endemic to the medical setting. If you think about also risk information about environment and other kind of products, this has been a major challenge as to how to impart this information in ways that people understand. But mainly what people, when it looked at genetic testing, they found that women either overestimate, they think that they are have really high probability of developing, much higher than it actually, or they really underestimate the risk of them developing breast cancer. And we know that there's a link between your risk perception, so how high or low do you think it is, with all sorts of things like emotional reaction, whether you feel anxiety, depression sometimes, and things like mammography testing. So if you think you're very high or very low, it might encourage you or motivate you to undergo testing, such as mammography, to see whether you should go any further with that. So I know that in California now there's no water, or supposedly there's no water. I don't know. At least Jerry Brown announced that you're going to cut. And I bring this example because people have looked, they said, okay, let's look at something very simple. So I want you imagine you were asked the question, after you read the statement, there is a 30% chance of rain tomorrow. And I give you three options. One is as to what does this statement mean. One, it will rain tomorrow in 30% of the region. It will rain tomorrow for 30% of the time. Or it will rain on 30% of days like tomorrow. How many would think number one is the correct answer? Are you raising your hand? Okay. We have two. How many think number two? 2, 3. How many think how many are waiting for 3? Overwhelming. It is the correct answer. Now, Americans might be really good when it comes to that. And it is true. Because when they ran the study in different kinds of countries, as you can see from this slide, so they ran it in New York, Amsterdam, Berlin, Milan, and Athens, they got a diverse set of answers. And it was kind of surprising because one might think that the question itself is rather not that difficult. But even something as simple as, or supposedly as straightforward, as simple as that, seems to create some challenges in people's interpretation. Just imagine what it means when it comes to lifetime risk. So this has been somewhat influential in our thinking about how do people understand probabilities and statistics in that sense. The last thing about the background that I want to mention is numeracy, which has been one factor that has gained much momentum. I think in the past 10 years, if you do anything to do with risk communication, if you don't include numeracy in one way or another, you're probably going to be reprimanded by the reviewers. So there's been a lot of work on the link between numeracy and understanding benefits of mammography. For example, people that are high or low on numeracy, how do they understand mammography testing, prenatal screening results, knowledge of health outcomes, different risk perception. We did work with Tom on Medicare Part D, and we showed that people that are higher in numeracy make better decisions in choosing health insurance. And there's been a whole host of areas also in the financial domain. People that are more numerate make better financial decisions. So this has been a really area that has captured the attention, and we wanted to capitalize on this to see whether actually people that are more numerate and less numerate do better in understanding that. So this is sort of what I said earlier. So if people have hard time understanding rather simple things such as weather, how would they do with something that is slightly more complicated, but because it's also slightly more emotional? I think that cancer does evoke a lot of feeling that probably the weather does not. But I don't know, maybe in California now, weather is slightly more emotive, especially if you're in agriculture, I suppose. So what we were interested in first is just trying to understand whether actually women understand correctly the statements about lifetime risk. If they don't understand it, then we can think of ways to improve it. So, and we were interested in the second part, is really capturing whether numeracy is related. We had, in the first study, we had about 250 women that were collected from all sorts of various internet sites. We posted ads in various internet sites, and you can see a little bit about the demographic. Very educated, well-off women in general that answered this survey. And what we did is we placed an ad. There was a possibility of winning some money for participation. We took information from the National Cancer Institute, which is, if you are not in the clinical setting, it's one of the main sources for the lay person. If you want to know something about cancer, this would be one of your best sources, most trusted sources of information. So this will be the kind of what you would read. According to estimate of lifetime risk, about 13%. And for those of you who know a little bit about this area, they give the information both in probability and in frequency. So they try to make it as easy for individuals to understand as possible. I looked yesterday on the numbers. The numbers have been revised. So I think that with more knowledge about genetics, those numbers change. But fundamentally, it doesn't matter if it's, I think it doesn't matter if it's 36 to 85 or 48 to 75. So those numbers does not, I don't think, I mean, I've not tested it, but I don't think that it would necessarily make a big difference for our, and we actually asked them, we said, you don't even have to compute, you just have to indicate which one you think is correct. Following the Giger answer kind of work about different ways of presenting it. So that was the first, they answered that, and they completed, for those of you who know, they completed a numeracy scale, and it has 11 questions, and this is one example. Imagine that we roll a fair 6-sided dice 1,000 times. Out of 1,000 rolls, how many will come even? And there's about 11 questions. People have used different tools in that domain. If you have interest in numeracy scales, I'm more than happy to help you with that afterwards. So in this sample, about half managed to choose the correct answer. They didn't know even what the interpretation of it. About half got it wrong, thought that 36 to 85% higher. And about 5% thought that it is something completely different, such as 36 to 85% of women will actually develop breast cancer, so which is fundamentally mistaken and kind of surprising for us was, I mean, the range of mistakes that women did. We also looked at some other factors. For those of you who know, typically cancer is increased, the rate of cancer increases with age. And so we were interested in what happens with age in that sense, and there is a slight decrease in your ability to answer it as we grow older for whatever reason. And education, the better educated you are, the better you do. And of course we were interested in numeracy, which is the main factor for us. And indeed we found that the more numerate you are, the better you do in this kind of task. So I don't know how many of you know about numeracy, but levels of numeracy are quite low. I think that the estimates of the average person is, if I remember correctly, is around 6-7 grade levels of numeracy. And it goes down with age. There are some studies that shows that as we get older, level of numeracy decline, and it has effect on a host of medical area. We did a split of the numeracy just to have a look, and you can see really how radically different it is in your ability to answer questions, whether you're high and low in numeracy. I think partially it's more like almost double the rate if you're high numeracy versus low numeracy. So we found in sample 1 that 50% are getting it wrong or right, depends on what you like, and that numeracy. But I think this is the expression, they didn't have any skin in the game, in the sense that these are general women, you know, they're maybe not interested in cancer, they never heard of breast cancer, maybe they didn't hear about genetics. So we thought that the next best thing is to go and ask women that actually might be more interested or might be at risk taking. And the other thing that we were interested is some of these objective numeracy scales have a problem because people don't like it, because they don't do well in the first or 2 questions, and then they disengage and they don't want to answer anything afterwards. So they get low numeracy scale more because of motivation rather than necessarily by ability. So some people have, out of Michigan, Peter Ubel and his colleagues have developed a subjective, which is more of something that you cannot really get the answer wrong. So it's more friendly, it's easier to do. So we included that in a second study. And so assume that you went through the genetic counseling, or that you really have a great interest in breast cancer because you are either at high risk or somebody in your family. So we contact another organization that is called FORCE. I don't know if some of you who are interested in cancer research might have heard. It's Facing a Risk of Cancer Empowerment. It's an organization in Florida that is an umbrella area or organization that basically tries to get individuals who are at high risk or have cancer, something like a support group that they can get information, they can learn, and they also aid researchers in some ways. And they were kind enough to allow us to send this study on their mailing list, so they basically send it to their around 5,000 women. I don't know how many they have now. We had a low return, but it's so 200 women responded to that. As you can see, slightly more, the education is probably more representative of the general population, unlike our previous studies. And we did the same thing. We gave them the same information and we asked them the same question, only this time we gave them this objective and subjective numeracy. Any estimates as to how things look now? So remember, many of those women underwent genetic testing. A good majority of them did. They all know about cancer, about breast cancer. Anybody has a prediction as to what will happen? What happened?
If they had counseling, and you said they did, then they should do much better.
Much better, right? You would expect that. So imagine they all went through the process. They did slightly better, but only slightly. This is just to give you a sense of the subjective numeracy. So how good are you with fractions? So can you compute 25% discount? These are the kind of questions that you can probably have a sense that it makes life slightly easier for participants because they don't have to really provide correct questions. So here, about 60 got it right. It's significantly different, but it's still 40% of them, slightly over the, don't get it right. And these are, again, women that went through the process, had counseling. Now, if our study was an isolated island, I think that it would be okay. But we know that in many cases, even when you catch women, not only women, just out the door from the consultation room, so they just ended the consultation with their either physician, they either don't remember the information or they get it wrong. Not necessarily only this information, but various others related to treatment, related to numbers. So this is a perpetual thing that you leave the consultation room and you don't know actually what the physician has told you. And remember, genetic testing partially is you go to your brother, sister, daughter, whoever it is, and you have to tell them the information. So what kind of information do you tell your daughter if you step out? We didn't ask that, but I think that it's one area of importance because now you can tell your 12-year-old daughter or your 6-year-old daughter or whatever it is, this kind of information. And what kind of information you give them obviously has a lot of bearing on their psychological dealing with this. Again, like the first study, the chances of correct decreased with age, it increased with education, and the subjective numeracy improved the results. And also objective numeracy improved the results. So we said, okay, this is again, we split the numeracy by high and low to show that again, numeracy really makes a difference. And the one thing that about numeracy is we can teach that, or possibly we can teach that. Unlike many others, maybe interventions, we can teach that at a very early age because we already do things that are not too remote from that in primary school and secondary school. We teach math, and maybe one way of improving those things is by actually bringing it into the primary school or high schools. And some there is, I'm not familiar with any data that has come out, but I know that some individuals have been conducting research along this line to see if it's improving. Just to compare it to the first study, participants did better, but as you saw, it's still 40% of them get it wrong. So it's not as if 98 suddenly got it right. And there was some slight variation in demographic between the two. So women who have undergone genetic testing or have been diagnosed with breast cancer perform better, but again, it's not a stellar performance in their results. Now, of course, the problem can be with the patient. The patients don't understand. The other problem can be maybe the doctors or whoever is conveying the information don't have a clue either what's going on, which is a possibility. So we know that some research that has been done shown when you present information or when you ask physicians about some statistical information, for example, they give them a positive results of mammography and they ask them, so what do you think is the probability that the woman actually has breast cancer? Most physicians get it wrong by, I think, a magnitude of 10 or something like that. Really big discrepancy between what reality is and what physicians get. I teach a little bit in the medical school at my university, and they have, I don't know how it is at UCLA, but they have quite limited education about statistics, and they have very limited knowledge about actually how to interpret test results, which is, I think, partially the business of physicians. Not their fault. It's possibly the educational system that is missing something. So we said, how about we do the same thing? And we asked 41 healthcare professionals, also through force, who had contact with them. The sample is slightly small, and it's genetic counselors, physicians, and nurses. There was an increase in quite substantial increase in the number who got it right. So 75% got it right. But at least 25% of them got it wrong. And these are individuals, by the way, all those are enforced because they are dealing with cancer and genetic testing. Those are not random nurses or doctors that we found from some other field. They're all oncologists or ones that are dealing with genetic, and still a quarter of them cannot get the answer right, which is slightly worrisome. In this case, numeracy was not associated with that, partially because, and that we can confirm from other studies, most physicians are really highly numerate. So this is probably one of the criteria that allows them to get into medical schools. They are very numerate, but numeracy does not always translate, obviously, into your ability to do those stats. So we thought that the trouble ends there, right? One problem with genetic testing, one problem with testing in general, is that we, as consumer of it, we want to know yes or no, right? Am I sick or not? However, genetic testing, at least with regard to breast cancer, doesn't work that way. You don't go to the consultation and get just a yes, no answer. You get mainly, we're not really sure, kind of. They call it, depends on the terminology. People have used, in the literature, they've used different terminology. But most cases, actually you get somewhat of an ambiguous test results, or what they call uninformative negative. So you sit there and you as a patient, so do I have it or I don't have it, right? Well, we cannot really tell. You have something. You have someone, so in the ambiguous, again, the language is slightly shifting as we know more. But in the ambiguous, you have some of your gene, there is some problem, but we're not sure if it's actually associated with cancer because the state of the knowledge does not allow us to do that. And sometimes you don't have, but you're the first person, so we're not sure. So you leave the consultation room actually a bit puzzled. So the question is, that as people have been asking, is how do we understand this thing? And we know from the literature that ambiguity is exceedingly, if just probability is hard to communicate, ambiguity is even harder. How do you tell somebody, look, it may be, we don't know. It's sort of you have, but not really. And people that have examined that have found that physicians use all sorts of language that actually does not make a lot of sense because they don't know how to really communicate that. It's, again, I'm not trying to blame physician or genetic counselor. It's just it's inherently difficult to communicate that information. And if you're a patient now, what do you tell your relatives? So sometimes you tell your family, I'm going to have the genetic testing, and you come back home and they say, so did you pass the test or not pass the test? Well, you don't really know if you passed the test or not, right? It's kind of difficult to know. and it complicates the decision. So what do you do in cases that it's unclear? So if you read the Angelina Jolie op-ed, there is no mention of the fact that a lot of women get ambiguous. It seems that everything is clear from her statement, which in her case, it's absolutely clear. I suppose it's absolutely clear. But for many women, it's not absolutely clear because they lived it with not such a clear statement. You have an 85, I think Angelina Jolie numbers was 85. She had a lifetime risk 85. They don't leave it with such a clear number. They leave it a far more ambiguous statement. So women, when they leave the consultation, when they ask them after that, many of them say, I'm definitely not a carrier. Some say, I'm definitely a carrier. Some say, I'm really confused. Which is, it's unclear actually which answer is always correct when you have that. If you think about, I mean, we're presenting it here with regard to medical setting, but think about the environment, and this has been a large discussion about environmental issue, about global warming or whatever. There is a lot of uncertainty there. Think about financial domain. There's a lot of uncertainty there. How people deal with it is very much akin to this area. But there's been a lot less research on this domain in the medical. What we know is that when you leave the consultation room with ambiguous, so when you leave it with true negative, obviously you're happy that you don't have it. But when you leave it with this ambiguous or uninformative negative, women experience high risk perception, so they think they're far higher. They are far more anxious about their state. Obviously, I mentioned confusion. They have a reduced sense of life quality. And there are people, and I don't know if you can classify yourself as one, that have what it's called ambiguity aversion. Some of us can thrive in this ambiguous state where things are unclear. Some of us really have challenges. When things are not clear, we really get frightened. And there is quite a bit of literature that when people go to be tested for cancer, sometimes they say, I'm really relieved that I found out that I have cancer because I was really, really anxious about not knowing. So many individuals are really suffering from this ambiguous state. So imagine now you leave the consultation again with this state of affairs. So what we try to do here is, again, try to understand how people understand it and test the link between numeracy and test results. So in this study, we contact the Cancer Genetic Network. Some of you might have heard it. I think they're based in Boston, but they have nodes around the country. It's basically another organization that individuals that are interested, who are cancer or at risk at cancer, sometimes with cancer, who are interested in helping researchers contact this network, and you can do all sorts of research with them. If you're interested, this is the link. They sort of died because the funding went dried. They still have a website, but there's not much going on. So we had almost 500 individuals from this, and some of them tested for BRCA. We didn't have response from many of them. Sort of representative. Again, we turned to the National Cancer Institute for information to see how they present the information, so we can do that. And we presented participant randomly one of the 4 test results. They saw all 4 test results. And this is just to give you an impression as to what you read. If genetic testing show a change in BRCA1 and BRCA2 that has been previously associated with cancer in other people, the person test results may be interpreted as ambiguous because everyone has genetic difference that are not associated with an increased risk of disease. It is sometimes not known whether a specific DNA change affects a person's risk of developing cancer. So direct scenarios like that about the ambiguous, and then they were asked to indicate what they think is the best answer with regard to the statement if that woman read that statement. We also asked them about positive test results, and because of the hype around the radical mastectomy, we wanted to see actually if you were that woman, what treatment option, because there are other treatment options. Radical mastectomy is sort of the extreme end. This is, I don't know, your last resort, but this is not where you start really with chopping. You want to try something less aggressive to see possibly, and we wanted to see whether women who might get a positive result, what kind of treatment they would in generally want to talk. Okay. So we presented to them the 4 options, and we told them what each option is, and we presented them. So when it's a positive result, everybody get it right. People understand what it means. You are at a higher risk. There's no really little. And then we asked them, actually, when we asked them what kind of treatment do you want, first they want the less aggressive one, which is surveillance. At least that's what they claim. And again, these are all women who know a lot about cancer. They either have a relative or they themselves. So it's not women that never heard of the phenomena. So surgery is down the line there. With the correct response, you can see that when it's positive, they know. When it's negative, they know. When it's becoming uninformative and ambiguous, they have a hard time deciphering precisely what is their risk, essentially. They don't know. This is what they answer just in the ambiguous. So the more likely it is, actually it's the more likely that is high, but if you get it, when it's the uninformative, they actually learn nothing from it. And about 45% of them understood that, but a good chunk of them failed to actually comprehend what those test results mean. Again, numeracy, regardless if you use objective or subjective, for those of you who are interested in utilizing those things, actually using the subjective sometimes seems like a good choice for. So what did we learn? Many women misinterpreted lifetime risk. It's a real challenge providing information that might seem like a straightforward information, but turns out to be quite challenging for women who have undergone testing and ones that have not, and to some degree, far lesser degree, also to healthcare professionals. The biggest challenge, I think, is understanding now this ambiguous and uninformative test result. There's been, relatively speaking, less information about that. The one concern about that is that genetic testing has been really pushed by what is called direct-to-consumer. There's one of the biggest company, 23andMe, received a letter about a year ago from the Federal Drug Administration actually shutting down their promotion of genetic testing, telling them basically, when you send the test results, people don't have a clue what you're talking about. And a friend of mine, I was telling him that about the kind of work, he's a PhD in biology, he works on genetics, he should be the prime candidate to understand that. But he did the 23andMe, he said he didn't comprehend actually what information they provided him. And this has been a great challenge for people who work in the area. 23andMe are back in business, but they're allowed to promote now, in my understanding, one test. They're not allowed to promote, as far as I know now. But it's only a question of time when it's back on the market, and we as individuals like me who are interested in that are to think of ways of, now we know that there's a problem, what can we do actually to improve it? And that's probably the next stage. I mentioned numeracy quite a bit. Obviously, there's some clinical implication for physicians, nurses, and genetic counselors. For example, especially pay attention to those patients that are low in numeracy. But we know actually the pressure that physicians have in the consultation. They barely have time to communicate anything with their patient, let alone to start and try and figure out your numeracy level and then try to fit the information to you. I want to end just by some quote from Angelina Jolie. That was about a week ago. She announced that she had her ovary removed as well. I did not do this slowly because I carry the BRCA gene, and I want other women to hear this. The positive BRCA test does not mean a lip to surgery. I've spoken to many doctors, surgeons, and naturopaths. There are other options. Some women take birth control pills or rely on alternative medicine combined with frequent checks. There's more than one way to deal with any health issue. The most important thing is to learn about the option and choose what is right for you personally. I think it's an interesting statement to end this here. Yeah? And of course, my collaborators.
We have time for about 10 minutes of questions. We have to leave at 5 minutes for one coach and other classes coming in, so please.
Yes, please.
Okay, thank you for your talk. It was really informative. So we do know that genetic testing is getting bigger in the United States, and we know, like, I'm very familiar with Oncotype DX because a lot of women use that test. And I guess, I don't know if this is a question or if I want to pick your brains a little. But let's say I was a researcher who is trying, to design a decision aid to help women who just recently got their Oncotype DX results. What do you think are key that we should have in a decision aid like that? Because you talked about numeracy.
Yeah.
But like, I mean, I guess from a patient perspective, like if I got a decision aid to help me with this, what do you think are the key elements that researchers should think about when you design such decision aids?
So I think the latest bridge is different presentation format. And we did some work in trying to present this information in different means to patients. I don't think it's shown too great success. So some have shown that presenting it with pictograms or graphical format can possibly aid, especially low numeracy individuals. So decision aids might use different presentation format to try and present this kind of information to patients. Unfortunately, I've not seen too many methods on how to improve it.
You mentioned back and forth in one of your slides. Can you talk a little bit about this, how back and forth could help?
You mean
I saw those words. I thought the idea was that you working between the clinician and the patient to make sure they understand it.
Yeah, but that would not be so much with a decision aid. I think decision aid is like a video that might be, or an app and I think people are going in that direction in trying to develop app e-health to assist. I think if I had, we've been thinking about what kind of app to develop for that can aid. And we find it extremely challenging to know precisely what to do. Peter Ubel has a number of papers, UBEL, and his colleague about sort of 10 or 8 ways to improve that. But it's very challenging to actually improve their understanding of numbers. I don't know back and forth if it necessarily will help and if it's actually feasible. So can you see going back and forth with your physician, discussing what the numbers meant? There's a sign outside my physician, I'm in the UK, one problem at a time or something like that, meaning I don't have time to talk about anything. One patient, one problem. I think that's what it says. I think she will be annoyed with me if I came back and said, I don't know, but it's a question. If you came to your physician and said, look, I didn't understand what this 30% means. Can you repeat it? There is some work about actually trying, not necessarily in psychology, trying to get individuals to repeat a task many times and see if they do better in that. And the question is, do you want to present them over and over the kind of information? You might also look Dominic Frosch's work, F-R-O-S-C-H, who did lots of work on decision aids with prostate cancer. And I don't know if Beth has done work on improving their understanding.
Not so much. I think those are good. Peter Ubel does a lot.
Yeah. Again, I spoke about breast cancer, but we did that with male, the same thing, and male do as bad. There's no gender differences with regard to that, so I don't want to, Yes, please.
Do patients with family histories of, the BRCA gene and cancer change how they respond?
So the women that we had, they had family, so they were on the register because they have a family. Yes, I didn't mention it, but they all were at high risk, and they were supposed to. They had those risk factors. So some of them even went through the process of genetic counseling and still find it challenging.
Sorry, I missed that.
Yeah, it's okay. It's okay. Yes, please.
I was going to say, can you speak to this issue of can we really teach numeracy at when we're adults? I mean, my kids, Common Core in California, I mean, this is a big deal, is this number sense issue of just breaking down numbers and trying to understand numbers. And my kids are too young to really go far into the fractions, but so I see this interest in teaching little kids, but is there good data on this? Not just in the context of a very narrow, but are we good at this?
I have not seen even data on young adults or in school level. So I mentioned, I know Gigerenzer has some project going on in trying to introduce both medical and financial literacy at young age. And Numeracy, in their idea, is introducing financial literacy and medical or health literacy at a young age. Also, how would you educate 50 years old? In what setting? I mean, I think it's an enormous challenge, but there have been task force in the United States that, I don't remember the term, but it's called Numeracy 2020. But it's unclear really, but it's unclear
What it means.
not just what it means, how to get there. So there is a strong policy desire, because policy makers actually realize that numeracy, or the ability to deal with number on a very limited level. So you don't need to do here any complicated math. And people are finding it challenging. It costs taxpayer in every country that you go, regardless, either because of people that make bad financial decisions, or health. And sometimes health also have financial ramifications. The two are combined, as for example in health insurance. So I don't know, I'll be between us. So for example, maybe for seniors, in senior centers. But I really don't have, and this require enormous financial investment on some level. So it's not going to be small programs to do that.
Maybe we just need an app.
Yeah.
One last question.
Yes, please.
So say you can teach numeracy, and say you can fully communicate to the patient exactly what their risks are, and you can even make them understand perfectly. You ask them all the questions you ask, and they get them right. But then, depending on their actual level of risk, there's still widely different decisions that the patients are making. So some patients really understand that they have a 1 in a million chance of, say, getting breast cancer, but they still want the mastectomy. Yes. Or on the other side, if they have a really high risk and they're young and they've got a family and they're so afraid of treatment, or they don't want to actually act on it, that they refuse treatment. Yeah. Is there sort of a next step for understanding that variation and somehow measuring the quality of the decision, how rational the decision-making process is?
That's an excellent question, which is obviously an empirical. I don't have any data about that, and I'm not familiar with any data that actually people have done this kind of study. But it's a question of, you raise a question of preferences. So if somebody has 1% chance of something happening and he builds an atomic bomb shelters, and then is it rational or not? It's a big question that what will be the rational choice, to lose the breast or not to lose the breast? I don't know, because for one, the anxiety that even if she doesn't develop breast cancer, the anxiety that living with that might be too much or will be a sufficient reason to go through the process. So you cannot say whether it is a rational or irrational, or maybe you can, but it's a difficult question to know what is a rational. Some physicians, following women's desire to do that, so say, following Angelina Jolie, they said some of the women are making bad preference choices. They haven't gone through the process. They're making bad because the risk is not high enough to do that. And some physicians can try to sway them from going in that direction. But it's really a difficult question as to what is the right decision.
Well, thank you very much.
Thank you.